Okay, so we're going to talk about how we use correlation to determine genetic risk. And one way we do this is to start with a group of what's called index cases or probands. And that is people who already have the diagnosis that we're interested in. So if we stay with our example of major depression, we would find a group of people who have been diagnosed with major depression, and then we look at their relatives to see the prevalence rates of depression in their relatives. And if we see higher prevalence rates in their relatives than we see in the general population, that might be an indication that the disorder is heritable, that there's a genetic risk, right? Because if there's no genetic risk, then their relatives should have the same prevalence rates as anyone does. But if there is a genetic risk, we might see higher prevalence rates in people who share genes with someone who's depressed than in people who don't share genes with the person who's depressed, right? So if there's a 16%, as we saw in that chart a few moments ago, 16% prevalence rate in the general population, and then you got a group of depressed people and look at their relatives, and it turns out major depression was occurring at a 30% rate in their relatives, that would be an indication that perhaps there was a genetic risk because it was occurring at higher rates in people that shared their genes. Another thing that we do is look at concordance among twin pairs. And so we might, in adoption studies, compare concordance rates, right, those correlation rates, between, again, a group of probands, right, people who are depressed, or index cases, and who have been adopted. And we compare the concordance rate, the similarity in depression rates with their biological relatives, and then also with their adopted relatives. And we would expect if what we're seeing, if there's a genetic risk, that we would see a higher concordance rate, a higher degree of similarity with their biological relatives than we do with their adoptive relatives. If it's more environmental, we'd see higher similarity or concordance rates with their adoptive relatives. And then where we've moved to is also just doing genome studies. And so looking at a group of depressed people and a group of non-depressed people, and looking to see whether certain alleles, remember we talked about allele variations, or certain single nucleotide polymorphisms, whether those occur at different rates in the depressed and non-depressed groups. And if they do, then we might say that there is a correlation between having this allele and being depressed, right? We still are not talking about causation, even though that's very tempting, because we're not manipulating anything. We're finding people as they are, and we can't be sure where causation lies, but we can say that people with this allele seem to be at greater risk for depression, and that's an appropriate way of talking about it. And so let's talk some about experimental design. We do sometimes use experiments when we're talking about psychopathology, not so much for risk factors, because we do that sometimes, but we're limited because of ethics and so what we can do. We certainly never want to cause somebody to be depressed to see if certain life experiences would make you depressed. But we use experimental design usually, most often probably for treatment outcome research. And here, if you remember what a placebo is from Psych 111, a placebo is something that mimics an actual treatment but doesn't provide the main component that we actually think causes change. And so the medication is the easiest way to talk about placebos. We might give the experimental group the actual medication, and then we give the control group a placebo, which is a pill that looks like the medication but doesn't have the active ingredient. And the reason for that is to keep it as similar as possible without actually giving the active ingredient. But we can also do treatment outcome even with psychotherapy, and so we have psychotherapy experiments where the experimental group gets the actual cognitive behavioral technique, for example, that we want to try out to treat depression or anxiety, and then the control group gets time with a therapist when the therapist is simply saying supportive things but not actually making an attempt to intervene with symptoms in any way. And what we would hope, if our treatment is effective, is that the experimental group improves to a much greater degree, to a significantly greater degree than the control group does. But there are also other kinds of experiments we can do that you probably did not hear about in Psych 111, and one of those is called an analog experiment. And here analog, right, means something like something analogous or an analogy. An analog experiment creates something that's similar to the thing we want to study without actually doing the thing we want to study, and again, that would be for ethical reasons. So the example we used before is, right, we couldn't cause a life experience, we couldn't expose our experimental group to a life experience that we thought might cause major depression, right? But we could do something much more low level that is similar, but doesn't have any lasting harm associated with it, to see if we can cause a similar kind of outcome. So, for example, we wouldn't want to cause an anxiety disorder, right? And so we wouldn't want to give somebody a traumatic event to see if we can cause post-traumatic stress disorder, right? But maybe we do some kind of low-level stress, the kind of stress that we might encounter routinely in our lives. And so in an experimental condition, we might give them an experience where they're taking a test, and no matter what they do, they're losing points, right? That would be very, very stressful. To see whether we can increase their anxiety symptoms through that condition. And so we take a baseline anxiety level, we do the intervention, and then we see if afterwards the experimental group has a higher report of anxiety than the control group that didn't have the stressful experience, who perhaps just takes the tests without being told they're getting anything wrong, right? And you might conclude from that failure experiences or experiences where we feel helpless, where we can't come up with the right answer, right? We feel helpless, might increase a sense of anxiety. And that would be helpful because it might help us understand how anxiety might start in some people, but it also might help us understand how to treat it more effectively. Single case experiments are called single case because essentially they use the same person or perhaps the same group of people to be their own control group. And these are sometimes called AB-AB designs, where the A is a baseline and the B is a treatment design. So the A is the control condition and the B is the treatment condition. And so you start, for example, if we take the same example we used in the last, when we were talking about analog experiments, perhaps what you do is you start with a group of people and you give them a typical exam where they are being told that they're getting lots of answers or even all answers right, and then you measure their anxiety after that. And then you bring them back the next day to take an exam where no matter what they do, they're failing every question. And then you measure their anxiety after that. And then you bring them back and you do another baseline, another control condition where they're taking an exam with success experiences. You measure anxiety, and then you give them the stressful exam experience again, and then you measure their anxiety. And so you're doing it with one group of people that are getting both conditions. This sometimes happens also with medication, especially when it feels unethical to deprive somebody of a medication, just put them in a control group where they never get the medication. You might have them at a baseline where they're just getting a placebo, and then you start the actual medication in the experimental condition, and then you bring them back to a baseline condition and back to an experimental condition to see how symptoms change in response to being on or off the medication. And then the last kind of research that you should know about that most of you probably haven't heard about until this point is that sometimes we do something called meta-analysis. And if I'm doing a meta-analytic study, what I do is I gather many examples of peer-reviewed research on a topic. So if I want to study stress and anxiety, I look at lots of other studies, hopefully exhaustive other studies that have been done on that topic. And then I use statistical models to kind of look at what they concluded from their data analysis in a broad way. So I can look at them all as a group and see whether, or kind of what the overall message is, what the overall finding is across all of those studies. And those can be really powerful studies if they're done well. There's also a whole lot of examples of meta-analytic studies that get great criticism for not doing it well and drawing conclusions that don't seem valid, that don't seem really to have statistical basis. I would suggest that as you're looking for peer-reviewed research, for example, for your group presentation, that right now you steer away from meta-analytic studies because I think that those can be really cumbersome to try to summarize. But in later work, if you were doing a larger paper, they can be really useful because if they're done well, they can give us very strong conclusions about a subject matter. So that's it. We have kind of shorter lecture for this topic than we have for others. You guys have your group work to do where you have an assigned research question to take a look at, and we will talk about that in our live discussion.